So while you collect your things, we at this point have public comment period. We have just one public commenter, but I would ask that person to come to the podium, David McKeon. SCNT. All right. Here. So while we're settling, right? So Mr. McKeon is from the New York Stem Cell Foundation. As per rule, public comments are restricted to 3 minutes, so please take that into account. I think the lights will probably tell you when your time is up, as they have been. So thank you for registering, and please, floor is yours.
Thanks for the committee and the staff for having me. I apologize for going so quickly, but I do have 3 minutes, so I'll try and go quickly. I work at the New York Stem Cell Foundation, where we've been collaborating with scientists at Columbia for a number of years to develop techniques for preventing the maternal transmission of mitochondrial DNA diseases. A child is going to be born every 30 minutes with a mitochondrial disease, and for women and their children and the many affected in the future, this work we're discussing today holds the promise of preventing the inheritance of these disorders. This technique allows women who are carriers of mitochondrial disease to have their own healthy biological children, while making sure that these children will not themselves be carriers of these terrible diseases. From research in our own laboratory and from research of others, we know that the technique should be effective and that mitochondrial replacement is fully compatible with a normal mitochondrial function. As we heard from Dr. Ward, and I think we'll hear later, we know that women want this, that they're ready for this to be available to them, and we need to do our best to make this available. I think it's also important to distinguish between mitochondrial replacement therapy and nuclear genome modification. They're two separate things, and we often invoke this fear of the slippery slope. And, sorry, this is pretty low. And that's not exactly what we're doing with mitochondrial replacement. It's not what we're doing at all. We're just, it does not enable the selection of any genes, in fact, and we're just selecting for a lack of defective mitochondria. This is different from human cloning. This is different from gene modification using CRISPR-Cas9. These topics need to be discussed separately, each on their own merits. So we also have the hypothetical concern that mitochondrial replacement could affect mitochondrial function. There's no scientific evidence that mitochondria and the nucleus of two different human subjects are not fully compatible when combined. MRT is the combination of naturally occurring genomes and is analogous to the genetic recombination in human reproduction. We can't be held hostage by the hypothetical concern when the concern of mitochondrial disease is very real. There's also the question of how currently available alternative approaches should be considered into the assessment of allowing this to move forward. While some will pursue alternative alternative options, we need to do everything possible to allow women all available options to grow their families. Existing options are not acceptable to many future parents, knowing that the technology could be made available to allow them to have genetically related healthy children. Detractors often take a paternalistic approach, suggesting affected women should build their families through these alternative methods, but they're not in a position to make decisions for others on this sensitive and complex subject. Today, we still see women with these diseases having children affected because of this desire to have a genetic link. And with the advent of these technologies, it's important that we give women all options to have healthy children that are genetically related to them. We need to give them the autonomy and the right to make their own informed decisions. So thanks for taking the leadership and hosting this meeting, and we appreciate all the work that you're doing to enhance this public dialogue. Thank you.
Thank you. So with that, we're to a break. My watch says 10 minutes to 3, so let's take 15 minutes and be back for 3:05.